Pediatric and Egyptian Scientific Society of Pediatric and Immunotherapy, and its continuous encouragement of continuous medical education and its effective and unique role offered by them today is the number 32 webinar of Egyptian Academy of Pediatric, and also is a very special day because it brings together three of giant of pediatric gastroenterology in the whole world. Let me introduce them. Professor Vandenplas. Professor Vandenplas, please welcome.
Hello.
Hi, nice to meet you.
Nice to meet you.
Yes, welcome again in Egypt.
Thank you.
Thank you. Professor Mostafa Hodhod.
Yes.
Mostafa.
Yes, Professor Dr. Wael. I'm with you.
Yes, nice to meet you. Welcome, my dear professor.
Thank you. Thank you, Dr. Wael.
Professor Marwa ElDeeb. Yes.
Hello.
Yes,
How are
I'm
you
very
all?
nice to be with us. Very nice
Thank
to be
you.
with
My
us.
pleasure.
And welcome to all.
Thank
Welcome
you
to
very
all.
much.
Welcome to all.
Thank
The floor to you, Professor Marwa.
Thank you very much, Professor Dr. Wael. Thank you. Assalamu alaikum, everyone. Good evening, everyone, everywhere. It's my extreme pleasure and honor to be among two very esteemed professors in the field of pediatric gastroenterology, discussing a very hot topic of cow milk allergy. I assure you that we'll have plenty of time for all your questions, but we'll keep the questions and answers for the end of the two speakers' presentations. I have only two remarks. Please, any questions, make sure that you put them in the Q&A part, because if you put them in the chat part, there's a big possibility that we're going to miss it. So please, again, all questions and answers in the Q&A part in front of you on the screen. We also have two poll questions before each presentation, before each talk. Voting on the poll question will be anonymous, so feel free. It's just a survey questions, no right or wrong answer, but they will enlighten us during the course of the presentation and talks. So I believe we can start now. The first poll question. So that's the first poll question, and you'll find an icon on your screen, poll. You can put on your answer here. So the first poll question: do you find the COMA score, the cow milk allergy symptom score, helpful to suspect cases with cow milk allergy? So it's yes, no, or I'm not aware of the score yet. So can you please vote? You have to vote in the poll part. Okay, great. So can we have the answer? Can we have the answer or not yet? Okay, this is lovely news. So I can find that most of you find the COMA score helpful, and that's great. That's great because I'll have now to introduce the founder of this COMA score. I'm very honored to have Professor Yvan Vandenplas with me today. Professor Yvan is an international figure in the field of pediatric gastroenterology and nutrition. He has wonderful original researches and articles and presentations in different areas of the field of pediatric gastroenterology. The list can go forever, Professor Yvan. It's our pleasure to have you today.
Thank you very much.
Thank you. Thank you. The screen is yours, Professor.
Thank you very much for the very nice introduction. And I was also very pleased with the answers to the question, because it shows that half of the audience does know the COMA score and finds it useful, and half of the audience does not yet know it. And we will convince them that COMA score is useful to help the diagnosis of cow's milk allergy. So the topic I was asked to share with you is about symptoms and diagnosis of cow's milk allergy. And although we tried it when we started, it moves. So this is the introduction of my presentation, followed by some slides on epidemiology, discuss a little bit symptoms, and then diagnosis.
Sorry, Professor Vandenplas, there is,
yes?
Please do share screen again.
Okay.
Yes.
Zoom.
Not yet.
Share screen.
Yes, not. Yes, okay. This is okay.
You see it now?
Thank you. Yes, okay. Thank you. We hear you well and we see it. Bye.
Okay, thank you. So it goes without saying that breastfeeding is, of course, the best way how to feed all infants. And breastfeeding is related to a lot of advantages compared to formula feeding. It's related to a lower risk for obesity. It helps brain development. It decreases the risk for sudden infant death. And last but not least, in the interest of the topic of the presentation of tonight, it reduces also the risk for allergies. So every effort should be made to stimulate breastfeeding as much as possible. But not every infant can be breastfed. And so we use cow's milk-based infant formula as the second choice infant feeding. Now, infants can react to cow's milk-based infant formula. They can develop what we call adverse reactions, which we can separate in immune-mediated reactions and non-immune mediated reactions. And of course, if it's non-immune mediated, it's per definition not allergic. And non-immune mediated reactions can be metabolic reactions, like happens in lactose intolerance. They can be toxic, they can be pharmacologic. But the topic of tonight is immune-mediated reactions, allergy, but also immune-mediated reactions are subdivided in different classes of reactions. Because it can be IgE-mediated, and that is relatively easy to recognize because that are acute reactions occurring a couple of minutes or 1 hour after the ingestion of the offending protein. But there are also, and probably it's most of the children who have non-IgE mediated allergy. And food-induced enteropathy is one example of that. And atopic dermatitis can be mixed. It means it can be IgE mediated and it can be non-IgE mediated. And besides that, there is a different mechanism, which is cell-mediated allergy, as occurs in contact dermatitis. So that's a fourth different pathophysiologic mechanism of immune-mediated diseases. Now, regarding cow's milk protein allergy and reactions to it, probably that a majority of the infants develop non-IgE mediated reactions, which are quite difficult to recognize because it may take days after the ingestion before the symptoms develop. The other important reaction is, as I said, IgE mediated, but they are relatively easy to recognize. A few slides, a few more data on epidemiology. How frequent is cow's milk protein allergy? Well, cow's milk protein allergy can develop in exclusively breastfed infants, but that's relatively rare. It's less than 0.5%. There are even key opinion leaders who think that it hardly really does not exist. While cow's milk protein allergy in formula-fed infants, according to literature, varies somewhere between 2 and 7%, and there is more or less consensus that probably the truth is between 3 and 4%. However, again, that depends, the incidence depends on the criteria for diagnosis and the population studied, because there is a huge discrepancy between perception and proven allergy by double-blind placebo-controlled food challenge. What I mean by that is that if you look at how frequent parents do have complaints that infants may have symptoms related to the ingestion of cosmic protein, that's probably about 10 to 15% of all the infants, while allergy proven by a double blind placebo-controlled food challenge, according to strict criteria, is sometimes in some studies 1% or even less. So there is a huge variation in literature, and it's still debated how frequent cosmic protein allergy really is. And the same debate is going on about the natural evolution of cosmic protein allergy, because the only reliable data that we have are data from tertiary care centers in selected populations. And what comes out from these centers is that about 50% of the children tolerate cow's milk allergy at the age of 1 year, 70% at 2 years, and almost 90%, so almost 100% at 3 years. Now, personally, I do think that at the age of 1 year, if you would look at the primary healthcare level, that development of tolerance is much higher than 50%. And I personally think that it's about 90% of the infants who already tolerate cosmic protein. But that's, of course, again related to how strict your diagnostic criteria are at the beginning and which population that you are studying, primary healthcare or selected severe affected children which are treated at tertiary healthcare centers. Now, IgE, you will hear that later, does not really have a role in the diagnosis of cosmic protein allergy, but it has a role in the prognosis, because the higher the IgE level, the more likely that the child will not develop tolerance. So what you see here is the blue line, which are the children with negative IgE. And you see that almost 100% of those children develop tolerance to cosmic protein. While if at the diagnosis, the IgE level is 50 or above, the red line, you see that only 50% of the children become tolerant to cosmic protein. So total IgE does not have a real interesting role in the diagnosis of cosmic protein allergy, but it is of major interest in the prognosis of cosmic protein allergy. It will help you to predict for you to the parents to say it's likely or it's very unlikely that your child will become tolerant to cosmic protein. Now, my idea that at the age of 1 year, about 90% of the infants are tolerating cow's milk protein comes also from the data from the EuroPreval birth cohort study, which was published now some 5 years ago. So first of all, for this study, the authors included only children with strict diagnostic criteria. And the conclusion was that only 0.5%, 0.5% of the children had challenge-proven cow's milk allergy, which is, of course, very low. But 25% of those children, according to these criteria, again, had non-IgE mediated cosmic protein allergy. Now, what is interesting that in this strictly selected population of infants, at the age of 1 year, 70% were already tolerating cosmic protein, and that all the children with non-IgE mediated cow's milk allergy, 100% of those with non-IgE mediated cow's milk allergy tolerated cosmic protein at the age of 1 year. So when a child does have non-IgE mediated cow's milk allergy, the natural history is that the vast majority, almost 100%, will develop tolerance to cosmic protein by the age of 1 year. Now, how to recognize symptoms of cow's milk protein allergy. The problem is that except for anaphylactic reaction, which fortunately is quite rare, none of the other symptoms is typical, is pathognomonic for the diagnosis of allergy. Any of those symptoms can occur as a consequence of other diseases. Now, how frequent does it occur? Now, if you look in children, in a group of children with cow's milk protein allergy, about 60% do have digestive symptoms, 30% do have respiratory symptoms, 70% do have skin symptoms, and about 50% do have general symptoms. Now, if you summarize this, this is 210%, which means that the vast majority of all the infants with cow's milk allergy do have a combination of symptoms involving different organ systems. So a combination of symptoms of skin with gastrointestinal tract or general symptoms with skin manifestations should make you as healthcare professional aware about the risk that allergy or an immune-mediated reaction may be causing these symptoms. Now, these are data from a recently published position paper from the European Academy of Allergology and Clinical Immunology about the symptoms of non-IgE mediated allergy in breastfed infants, but the same is true for the formula-fed infants. And again, you have reactions which occur quite rapidly within 1 day, or you have reactions would take 1 to 3 days before they develop, or you have reactions would take more than 3 days before they develop. And so depending on the speed of when symptoms develop, it's more or less easy to suspect cow's milk allergy. Now, one of the manifestations of cow's milk allergy, which is often forgotten and which is relatively new and which is also relatively rare, is food protein-induced enterocolitis syndrome or food protein-induced allergic proctocolitis. Both may seem quite similar, but they are quite different because FPAP, the allergic proctocolitis, occurs mainly in very young infants and a lot in exclusively breastfed infants, 40%. And it's always due to cow's milk. While the FPIES, the food protein-induced enterocolitis syndrome, occurs in older children, 4 months old, only 20% is exclusively breastfed, and it's also caused by other proteins than cow's milk, although cow's milk is causing the symptoms in 75% of all the infants. Tolerance for development of cow's milk protein is almost 100% in the FPIP by the age of 2 years, while only 60% in those with food protein-induced enterocolitis syndrome. So it's more or less the same, but FPAP, the allergic proctocolitis, is much more benign than the enterocolitis syndrome. And then another manifestation is eosinophilic esophagitis. And of course, the only way how to make the separation between gastroesophageal reflux disease and reflux symptoms caused by allergic reactions by eosinophilic esophagitis is by endoscopy and biopsies. And the symptoms of eosinophilic esophagitis in older children and adults, it's mainly dysphagia. When they eat solid food, they have to drink to get the food down into their stomach. But for infants, the symptoms of eosinophilic esophagitis are absolutely overlapping with the symptoms of gastroesophageal reflux disease. So whenever you have a child that you diagnosed with reflux disease and he does not respond to the treatment you installed, think about allergy, think about eosinophilic esophagitis. So again, from our paper on breastfed infants and non-IgE gastrointestinal allergies, just to remind you that there are no data which suggest reflux as a single manifestation of allergy, that there are no data for constipation as a single manifestation of food allergy. There are almost no data for infantile colic as single manifestation. So again, it's combination of symptoms which should make you aware about the possibility of allergy causing the problems. So how are we going to diagnose allergy? As I already mentioned, skin prick test, IgE, and specific rust do not really contribute. You can perform them, but negative results do not inform you a lot, because a lot of children, mainly all those with non-IgE mediated allergy, will have negative skin prick test, negative specific rust. So normal results do certainly not exclude allergy. On the other side, false positive results do also exist, although they are much more seldom than the false negative results. But so even a positive result is not an absolute proof of the child being allergic. So there is not one laboratory test that diagnoses specifically cosmic protein allergy. So what do we say? Well, the diagnosis, the golden standard is elimination diet. And then when the symptoms disappeared, challenge again. And according to this position paper from the European Academy of Allergology and Clinical Immunology from some 15 years ago, in young children, infants, which is the age which we are talking about tonight, an open challenge controlled and evaluated by a physician is most often sufficient. So it does not always have to be in the hospital, but it needs medical supervision, and an open challenge test is sufficient. How should you perform the challenge test? Well, for young infants, it's recommended to do that with standard infant cow's milk-based infant formula. How to perform that? Well, there are no comparative trials, which is the best way how to perform a challenge test. There are different methods how to perform a challenge test. But what is illustrated here, the method that you see at the right part of this slide, is the one which was mentioned about 8 years ago in the ESSPN from the European Society of Pediatric Gastroenterology, Hepatology and Nutrition guidelines. And we took that over in the more recent published guidelines for the Middle East consensus. So what is important is that gradually you reach up to 100 milliliters of intake, and that you then still observe the child for 2 hours under medical supervision. So a challenge test takes about half a day. And then also very important is that you continue the challenge test if the child did not react. So each day of the week, the child should drink at least 250 milliliters of milk, and that should be documented, because if after 1 day the child stops drinking cow's milk or drinks small amount, then your challenge test is methodologically probably not valid. So challenges should not always be carried out in a hospital, as I said, but it should be performed in a hospital setting when there is a previous history of an immediate allergic reaction, when the reaction is unpredictable, and in cases of severe atopic dermatitis. So that's what the guidelines say. Elimination diet for 2 to 4 weeks, followed by reintroduction in the breastfed baby, the mother that drinks cow's milk again, or a challenge test in the formula-fed baby. But of course, it does not really make you the difference between immune-mediated reactions and not immune-mediated reaction. Because if the child does have a functional gastrointestinal disorder as a consequence of the contact with cow's milk protein, the child will also relapse. But even more striking is that although the challenge test is mandatory, and we all agree with that, it's in reality often very difficult to convince the parents to accept that challenge test, because many parents refuse that challenge test, because what we do is we make the child sick again, and parents refuse to do so if the child tolerates that elimination diet very well. They just want to continue with that elimination diet. The high frequency of parents refusing a challenge test is illustrated from this clinical trial. What we did do in Belgium is a multi-center comparative trial between two extensive hydrolysates, one from Nestle Altera, to not name it, and one from Mead Johnson, Nutramigen, to not name it. And the idea was to show that they were both equally active in treating cosmic protein allergy. But parents, mother and father, had to sign an informed consent that they would agree with a challenge test after 2 to 4 weeks of that elimination diet. And so despite that parents were informed in study conditions that they did sign a contract with the study coordinators, 25% refused to do the challenge test because the child was going better. So in daily life, performing a challenge test is not always easy. So because of all these difficulties, together with a group of quarters, we developed the COMI score, the cow's milk symptom score, as an awareness tool for the diagnosis of cosmic protein allergy. It's not a diagnostic tool yet because it has not been validated. But what did we do? We selected the most frequent symptoms of cosmic protein allergy: digestive symptoms, regurgitation, stool symptoms as well, hard stools as diarrhea, scored them between 0 and 6 from very mild to severe. We looked at general symptoms as crying, also gave there a score from 0 to 6 depending on the number of hours per day the child was crying. We looked for skin manifestations, atopic dermatitis and urticaria, also scores from 0 to 6. And respiratory symptoms, which account only for half, because most of the time respiratory symptoms in infants under 1 year are of course caused by viral infections. But still everyone agrees that they can be also a consequence of allergy. So the COMI score ranges from 0 to 33. And what we did do is we measured the COMI score in a presumed healthy population of infants. And what we noticed then is that the percentile 95 of this COMI score in healthy infants was a score of 9. So if you have a score of 10 or above, then your score is above the percentile 95 and is very likely to be abnormal and is an awareness tool for these symptoms may be possibly caused by cosmic protein allergy. This COMI score has been used in 3 different clinical trials, overall 170 infants included. And you see that that score is 13 as a medium value at inclusion, and after 1 month, it's only 5. And the diagnosis of cosmic protein allergy in those 3 trials was a positive challenge test. And what we could demonstrate is that the positive predictive value of a high COMI score of 10 or more to have cosmic protein allergy was 75%, which is much better than any other diagnostic test for cosmic protein allergy that exists, much better than IgE, much better than skin prick test. Of course, with a challenge test being the golden standard. That brings me to the conclusion of my presentation. Again, breastfeeding is of course the best way to feed all infants. It protects against illness and infection in infants and children and should be stimulated as much as possible. But the diagnosis of cow's milk allergy in formula-fed infants is not easy. It's not easy because there is on one side a lack of awareness and training. A lot of healthcare providers worldwide are not well trained for the diagnosis, but there is also, there is no formal education, but there is no specific nature of the symptoms, and we have no good diagnostic test available except for the challenge test, which is the golden standard. And now probably the COMI score, which will help you to think about allergy for those infants who have a little bit symptoms of the gastrointestinal tract, respiratory tract, skin symptoms, a combination of symptoms. But if you have a positive score, then cosmic protein allergy becomes very likely as a diagnosis. So it's quite confusing to diagnose cosmic protein allergy because the symptoms are aspecific. There is no really good diagnostic tool, but think about it and evaluate the COSMIL score, the COMI score. It will probably help you to more frequently think about allergy. Thank you for your attention.
Oh, thank you very much. Thank you very much, Professor Yvan, for this very nice illustrative presentation. Thank you very much. We're having lots of questions as expected, and we're getting more as we're talking. Okay, so I'll just go to the second poll question and to Professor Hodhod talk and back to the questions.
Yes,
thank you
fine.
very much.
Pleasure.
Thank you. So can we have the second poll question, please? Okay, so that's the second poll question. It's about formula choice in patients or in infants with cow milk allergy. Of course, if they're formula fed. In choosing a formula, you need to consider palatability, the taste, cost, availability, the degree of protein hydrolysis, whether partial or extensive or amino acid, or you might have other consideration in choosing the formula that we'd love to know about. So please take your time and vote on the poll part at the bottom of the screen. And again, there is no right and wrong answer, just feel free. Okay, so do we have the results of the poll? Okay, this is very impressive. I think Professor Hodhod will like this very much. So most of the attendees agree that we have to consider the degree of protein hydrolysis, and comes second is the palatability and the availability of the formula. Thank you very much. And indeed, it's my pleasure personally to introduce my professor, Professor Dr. Mostafa Hodhod, a pioneer figure in the field of pediatric gastroenterology and nutrition. Professor Mostafa is the head of Pediatric unit at Ain Shams University. He's the founder of the Pediatric Gastroenterology and Endoscopy unit at Ain Shams University. He has a lot of other titles, a certified international trainer, a very distinguished member of the Research Ethics Committee at Ain Shams University and also at the Egyptian Ministry of Health. It's my pleasure, and I can end my career right now introducing my professor. He will enlighten us on the management of cow milk allergy and the different formula choice that we have. The screen is yours, Professor Mostafa.
Thank you, Professor Marwa. I know it is difficult to speak after the leader of allergy, Professor Vandenplas, and I know after this fascinating talk by the leading professor, it is difficult to discuss anything more, but let me go with you through the cow milk protein allergy management positioning of amino acid-based formula. This talk is sponsored by Abbott Nutrition without any interference with its scientific contents. And if you want to trace my research profile, you can find this Google Scholar link. So let us start with the treatment. What is the standard international guidelines recommendation for the treatment of cow's milk protein allergy? We can find here ESSPN and NICE guidelines. For the ESSPN, it's one statement: the strict avoidance of cow's milk protein is presently the safest strategy for managing cow milk protein allergy. Is it the end of the thing? I don't think so. You can follow me to see. NICE guidelines are not different, discussing the avoidance of offending food and emergency treatment of the adverse reactions are the mainstay in the management of whether IgE or non-IgE mediated disease. So if we proceeded about the intervention strategies in cow's milk protein allergy, overall we have 3 levels. Primary prevention of initial IgE sensitization. Secondly, prevention of the triggering allergic reactions to interrupt the development of food allergy in IgE sensitized children. And tertiary prevention to reduce the manifestation of end-organ allergic disease in children with established food allergy via avoidance of allergenic food and induction of tolerance. And if we looked at this diagram by Shekson et al. 2019, and here they put the extensively hydrolyzed formula in addition to brew or prebiotics, induction of tolerance by oral immunotherapy, baked milk products if tolerated, and if breast milk is not enough, which means that if breast milk is enough, it should be the first line of feeding in these persons. You can consider extensively hydrolyzed formula if tolerated and amino acid-based formula in severe cases. And of course, breastfeeding itself is not only the best way, but it is one of the most important preventive tools is to have exclusive breastfeeding from the very early beginning. Avoidance of milk and milk-related products. You can look here that some of the processes may start in childhood, like oral immunotherapy that needs to start after the age of 3 years, and elimination is the standard golden way and rule, starting from birth to even adolescence when an allergy was diagnosed. And this is a very complex diagram summarizing the process of strict elimination, and we are going to illustrate more and more by it. Considering the oral immunotherapy, a meta-analysis of Cochrane collaboration concluded that oral immunotherapy is effective for inducing desensitization in IgE-mediated disease. I stress here, it is for IgE-mediated cow milk protein allergy. While mild and self-limiting, in most cases, adverse events can be observed with this oral immunotherapy, and these adverse events most commonly occur in the gastrointestinal tract, and on top, eosinophilic esophagitis is of particular concern because it occurs significantly with oral immunotherapy. And 5.3% of patients receiving food OIT with the diagnosis of EOE by biopsy findings as a result of this immunotherapy. This observation suggests that food oral immunotherapy could increase the risk of EOE development. In fact, in my experience, I think this study needs, these studies about the eosinophilic esophagitis did not consider one important item. The difference between IgE-mediated disease and non-IgE-mediated disease may be confusing because the classification was according to the which is pathogenic, an IgE-mediated pathology or not. So in some cases of non-IgE-mediated disease, they find a little bit elevation of IgE and they consider it as a possibility for oral immunotherapy. And if they started oral immunotherapy here in a non-IgE mediated disease, they may have appearance of the manifestation that already were present before this challenge. So I think this area needs to be more studied. What will happen for breastfed infants? Breastfeeding is strongly recommended according to all guidelines and according to nature and according to religions. as the preferred way of infant feeding. Mothers should be encouraged to continue breastfeeding while avoiding all milk and the dairy products from their own diet. And according to the ESSPN, it is strict elimination. And actually, this breastfeeding is essential, as we said. And in my practice, I meet many conditions in which the physician had stopped the breastfeeding on the assumption that it is the cause. It is the food of the mother that should be eliminated, and the breastfeeding should be continued as well. Are we going to avoid any food else in cow's milk protein allergy, and which foods we are going to avoid? All milk products and milk-containing foods. And this usually requires qualified dietary counseling by a dietitian or a clinical nutritionist to exclude hidden sources of cow milk protein allergy, and this is an ESSPN recommendation. The second question will be, is there cross-reactivity between cow's milk protein and other food? And actually, in this diagram, you can see cow's milk with beef about 10%, although two single studies, very small studies in Egypt, one demonstrated 33% coincidence of beef allergy with cow's milk allergy, and the other one reported 67% coincidence, but the international literature speaks about 10%. Goat's milk cross-reactivity with cow's milk is almost 92%, a very high percentage that means we should avoid the goat's milk in these conditions. And interestingly, mare's milk is only cross-antigenic within a 4%, which makes it a good alternative in cases with cow's milk allergy. Foodstuffs that, such as almond milk or other alternative milk beverages, are not suitable for nutritional needs. And actually, they are not milks. They are milks by name, but they are not milks in truth. Industrial juices are improperly called milk, as we said, and they totally unsuitable for nutritional needs, according to ESSPN. What about goat's milk? As we said, it's not sufficient. It is cross-antigenic. It's not an alternative in these conditions. By the way, in 1990s, I tried for 3 years an alternative tool by camel milk, and actually it failed. Is milk remedy different according to disease? Amino acid-based formula assures fast symptom resolution and supports growth. In cow's milk allergy, in multiple food allergy, in atopic dermatitis, in gastroesophageal reflux disease presenting feature of esophageal eosinophilia, eosinophilic esophagitis, short bowel, and other GI conditions. Efficacy criteria of any amino acid-based formula should entail that this formula is a hypoallergic one, needing appropriate testing, demonstrating not to provoke reactions in 90% of infants with a confidence interval of a confidence level of 95%, or children confirmed cow milk allergy in a prospective randomized double-blind placebo-controlled trial. If it is not that, this is not a suitable amino acid combination. And its amino acid profile should go parallel to the amino acid profile as shown in this figure with the breast milk proteins. And actually, we mentioned eosinophilic esophagitis, and amino acid-based formula was tried in many studies, but in this study, in 10 children, complete resolution in 8 children, and significant improvement of symptoms in 2 children happened, with decrease of the eosinophilic count in the esophageal mucosa was achieved significantly with amino acid-based formula. And you can see here how much the eosinophilic count decreased from the pre-dietary trial to the post-dietary trial. And this is, again, the symptomatology happening in persons administration of the amino acid-based formula and in the post-dietary manipulation regarding this symptomatology. You can find that eosinophilic count will decrease in the biopsies, abdominal pain will significantly decrease, vomiting, heartburn, motor thrush, globus, dysphagia, all will decrease. However, some other manifestations will not improve, and mostly they are related to the dysmotility happening that may persist for a long period. Which milk is the first choice and which milk is second choice and which milk is not in the first or second choice? You can see here that we are alternating between amino acid-based formula and the eosinophilic and the extensively hydrolyzed formula in the different syndromes of cow's milk protein allergy and the food allergies. For example, here, no place for thing except amino acid-based formula in anaphylaxis. And in F-BIES, amino acid-based formula is indicated. F-BIES, which is food protein-induced enterocolitis syndrome that may range from a mild condition to a severe fatal condition. Again, allergic eosinophilic esophagitis, there is no second choice. It is only amino acid-based formula and no second choice. And inhaler syndrome, that is pulmonary hemosiderosis associated with cow's milk protein allergy, this is first choice is amino acid-based formula, and you may use as a second alternative soy-based formula. And this is the only place in second choice for soy-based formula in this table. This table was introduced by World Allergy Organization 2016. It goes without saying that if we started with extensively hydrolyzed formula and the problems happen, that in this place amino acid formula will come immediately to have its place. And we cannot forget that if you are doing the elimination part of the eliminatory challenge discussed by Professor Vandenplas in an formula-fed infant, it is most reliable to put this child on an amino acid-based formula. We should achieve some helpful features. It should be effective and safe. So reports in the studies should show the efficacy of this formula. And no allergy should happen on its use. Bone health. Rapid growth and demineralization of infant skeleton requires adequate supplies of calcium, magnesium, and vitamin D. And I want to stress here on the fact that fat blend that is free of palm oil as a source of fatty acids is better for bone mineralization, because if this palm oil is used, the free oleic acid will lead to saponification with calcium, and the calcium is going to be lost in the stool. Growth and gastrointestinal functions, according to different studies, amino acid-based formula should provide comparable growth tolerance and the protein status in health-term infants when compared to infants fed a casein hydrolysate formula. Gastrointestinal symptoms are better controlled by the amino acid-based formula. It should also maintain a normal iron profile. And here you can see the report by physician rated symptom score, how much is it decreased, and what about the number of stool decreasing after the use of the amino acid form. Fat blend. The fat blend contains 33% of medium chain triglyceride that are easily absorbed and does not need the lymphatic absorption and micelle formation. What about the IQ? That is iron the brain system. You should supply the long chain polyunsaturated fatty acids because they are important for the brain and eye development. And in addition to the other IQ ingredients that are taurine, choline, iron, and zinc that are vital to brain and eye development. In one of the studies about amino acid-based formula, in whom extensively hydrolyzed protein formula was not helpful and infants are not responding. In this observational prospective study that included 30 infants with a history of loss of weight, persistent allergic manifestations while on an extensive hydrolyzed formula, they were given amino acid-based formula for 12 weeks. Mean weight gain improved after the 12 weeks feeding period. Improvement was observed for many allergic symptoms, including significant decrease in atopic dermatitis severity. These results indicate that amino acid-based infant formula supported healthy weight gain and improvement in allergic manifestations in infants not responding to extensively hydrolyzed formula. In this another study that was published 2018 about amino acid-based formula in premature, they compared the study assessed the fecal calprotectin level in amino acid-based fed infants with feeding intolerance. They are premature with feeding intolerance, and it showed significantly lower levels than those on breast milk or premature formula fed infants. Actually, for this study, I think more clinical outcome should be evaluated rather than a surrogate marker, which is fecal calprotectin. And I think this is just an open, which allows more further studies to assess clinical outcomes like duration of symptoms, duration to reach the full tolerance to food, symptom follow-up after discharge from the NICU, and so on. These are called clinical outcome parameters, and it's well known that clinical outcome is more strong evidence than the surrogate marker outcome studies like this one studying the fecal calprotectin. Actually, you see here that fecal calprotectin was significantly higher and it's lower in amino acid-based formula. What about the growth in these persons extensively hydrolyzed or in amino acid-based? And according to this study, 2018, results suggested that healthy infants receiving commonly available extensively hydrolyzed formula and amino acid-based formula do not appear to experience accelerated growth as reported for infants fed many standard formula. What does this mean? Any infant on hypoallergenic formula, whether it is amino acid or extensively hydrolyzed, we don't expect to have the same growth rate like that in standard formula. Difference in growth parameters were observed with some formulas supporting normal growth patterns and others not. Are you ready to go with me more deeper with this study to see what happened? In this study, they have studied 4 extensively hydrolyzed formula, A, B, C, D, and 5 amino acid-based formula, E to I. And what happened? You can see here that mean weight gain is almost comparable between them, with some being lower and some being upper. This is about how many grams are increasing weight per day. And you can see in this diagram of this study that formula E, remember that formula E was, we are going back, formula E was ElDeeb infant. And you can see here that this score for weight, for age, was the best achieved by formula E compared to all extensively hydrolyzed formula A to D. And this is another table of this study that compared different forms together. And one of the comparisons were between an extensively hydrolyzed formula and formula E, which is ElDeeb. Daily weight gain was similar between extensively hydrolyzed and amino acid-based formula, with a dropout rate 39 compared to 35 of extensively hydrolyzed. What does this mean? Dropout rate may mean the palatability, and because the percent is almost near to each other, you can find here that drop rate is similar, almost similar between both. You can see that some others amino acid based formula, the drop rate may reach 40 or 47% of the cases on this medicine, of this form. What happened when they compare the different amino acid based formulas together? Body weight centiles of evaluable health term male infants fed amino acid E, remember E, were at 60 centile at the start and tracked very close to the 50th all through the 4 months of life. And this is according to Partial et al. So what it means that you are going to maintain the persons on this amino acid form that is E form, code E for ElDeeb, and at that time they are maintained around the 50th centile. In contrast, other amino acids started with a centile of 50th, but actually they dropped to the 30th or 50th centile, and this is a significant drop. However, all are within the normal range of centiles. Mean weight gain from 14 to 112 or 120 days of age ranged between 27 to 29 in all amino acid based formulas, and this was similar to what was described in breastfed infants. Body mass index of healthy term infants fed the formula E amino acid base at 14 and 112 days of age was determined in an ad hoc analysis from one of the reported studies. According to this review, systematic review, the mean body mass index of infants was 14 at 14 days of age, and it increased to 16.7 by the age of 112 days of age. And this means that this formula of amino acid based formula is actually increasing the weight and increasing the maintaining the centiles almost at 50s, and it also increases the body mass index. Now we know what milk to give and when to refer your patients. When to refer to second care in established diagnosis case according to NICE guidelines 2011. An acute systemic reaction happened, you should refer. A severe delayed reaction, faltering growth in combination with one or more of the gastrointestinal symptoms, significant atopic eczema where multiple or cross-reactive food allergies are suspected, those who have not responding to single allergen elimination diet, please do not go ahead alone to eliminate more and more and more, because at this stage, many assessment tools are needed, both for discovering mimickers of allergy. It might be something else. For example, very early onset IBD, eosinophilic GI disease. And remember, in our country and in the Middle East, consanguinity is very high. And the consanguinity will lead to development of many autosomal recessive disorders. Examples of this are the very early onset IBD. And I wonder when I find reports of few cases of very early onset IBD, while I'm following almost 80 cases of very early onset IBD, and this is back to the consanguinity level in our community. Those with asthma who have confirmed IgE-mediated food allergy should be referred. Those in whom there is a strong clinical suspicion of IgE-mediated disease, but tests are negative, please refer. Persistent parental suspicion of food allergy in spite of your analysis, please refer. Clinical suspicion of multiple food allergies, please refer. So we are coming to the end. In formula-fed, elimination test is better achieved by amino acid-based formula. For treatment, breastfeeding with maternal strict elimination is the standard rule. In formula-fed, define your diagnosis to choose the formula. You should have the diagnosis. It's not only cow's milk allergy. We have different syndromes occurring inside. To choose the formula, amino acid-based formula is very safe and very effective. It's used in significant and complicated cases as first choice, and in all cases, if they were not responding to extensively hydrolyzed formula. Thank you.
Thank you very much. Thank you very much, Professor Mostafa, for this very comprehensive talk on the choice of the formula and the management. Ready for the questions? We have lots and lots of questions. So can we join Professor Yvan, please? Professor Yvan?
Yeah.
Yeah, okay. I'm happy to tell you, I'm not sure if you'll be happy to, that we have lots of questions on each and every part of your presentations. The part of the symptoms, the part on the investigations, the part on the choice of formula. We have lots of questions from every part of the world. I was actually surprised to have some questions from Germany as well. So yeah, so I think we'll have a lot of time discussing these questions. So allow me first, Professor Yvan, this question on the symptoms. How sensitive and specific is the COMIS score?
Well, that's a very good question, because it's for absolutely not a tool that will diagnose every or pick up every child with cow's milk allergy, because it's mostly intended for non-IgE mediated allergy. A child would develop an anaphylactic reaction will have a negative COMIS score. So you can certainly have low scores and be allergic. Blood in the stools is one of the parameters which is not included in the COMIS, and we did that because it's very frequently also the consequence of infectious disease. So whenever you have a high score, I think the positive predictive value for cow's milk allergy is relatively high, but low scores do not exclude cow's milk allergy. That should be clear.
Yeah, I think that's clear. Professor Mostafa, would you like to comment on how much do we use the COMIS score in the Egyptian population and the Egyptian, in Egypt, I mean? Yeah.
Dr. Marwa, thank you. And I think when we started to discuss in lectures the COMIS score introduced by Professor Vandenplas in the last 3 years or something, many persons became aware, but in my opinion, even those who are aware of the symptom score, they are two categories. Category who can diagnose based on this score, and usually we stress on the fact today mentioned by Professor Vandenplas that this is an awareness tool rather than a diagnostic test. However, many cases were diagnosed by colleagues as cow's milk allergy based on COMIS score. Others are missing the diagnosis, although if they apply the COMIS score, it achieves almost something above 25 score, and they have missed the case as well. So from this platform, I remind my colleagues in Egypt and the Middle East that this is a very helpful tool. And I saw here that Professor Vandenplas decreased the cutoff value to 10 instead of 12. And I know that this was a study ongoing in the last 2 years. And this is very good. This is very good.
Well, it's true that initial proposal was 12 and above, but that was just by consensus without having any data. And now that we have data in a normal population, I think we should use the percentile 95 as we do in pediatrics for weight gain or whatever. Below percentile 3 and above percentile 95 should get our attention. And it's not per definition abnormal, being above percentile 95, but it makes it very likely that there is something going on. So it's really an awareness tool, and it's to help our colleagues think if they summarize all the different symptoms that an infant may have, that then overall that score becomes quite high, and then the diagnosis of allergy becomes likely.
More likely, yes, yes. Thank you very much for this point. And I'll take it from here, Professor Yvan, and a question asking about: can you still suspect and diagnose cow milk allergy without any GI manifestations?
Yes, of course.
Yeah, right. If you just apply the comments, you can suspect and diagnose. Exactly.
Yeah, absolutely clear.
Yeah. Okay. Can you diagnose cow milk allergy with only respiratory manifestations? Another question.
Yes, it certainly exists, but that is relatively rare, because not many infants present with symptoms in only one organ system, and respiratory symptoms in infants is most of the time of infectious origin, but it's possible that the origin is allergic also.
Oh, yeah, thank you very much on this. Professor Mostafa, this is a question to you from Professor Muhammad Rez, the head of Pediatric Gastroenterology in Mansoura, specifically addressing you on the issue. Muhammad. Yeah. On the issue of gastroesophageal reflux and allergy. So would you start first treatment, pharmacological treatment, or you will start first a trial of elimination? Diagnostic,
I know Professor Muhammad is trying to stress on this point because we were together in the consensus for gastroesophageal reflux disease in Egyptian community, pediatric community, and we agreed with the combined opinion of Naspigen and Espigen that considered an elimination interval of 2 to 4 weeks prior to starting the pharmacological therapy. Actually, one of the choosing wisely areas in pediatric practice now is the use of PPIs. And we are afraid of the abuse of proton pump inhibitors. Yeah. And actually, although it's almost just 1/4, 25% of persons presenting with gastroesophageal reflux disease might prove to be of allergic origin, the consensus was to start elimination prior to medical therapy. And I agree with this idea. And in one of our studies that were not published yet, we compared a placebo-controlled trial of PPIs in a clinical trial between placebo and one of the PPIs, in addition to elimination. And we found very interesting finding. If you combine the elimination with the PPIs, you start control earlier. But at the end of the day, by almost 6 weeks, you are having the same results of elimination alone or elimination plus PPI. So in my practice, Professor Marwa, sometimes if the symptoms are severe and mother is very anxious, especially those having the postpartum depression, I may combine both for a while, then removing the PPIs after that. And in most of the cases, I usually start the elimination according to the guidelines, and improvement will happen. And according to this study, that was one of the PhD theses done in Ain Shams University Pediatric Hospital.
Yes. Okay. Thank you very much, Professor Mostafa. Professor Yvan, do you have to comment on this question? Gerd?
Yeah. Well, I can only agree with what has been said. I think there is worldwide overuse of proton pump inhibitors. Yes. We are really trying to fight it. 2 additional comments is that about 30% of the infants on PPI develop small intestinal bacterial overgrowth, which are exactly the same symptoms as why the PPI was prescribed. That's one thing. And the second thing is that PPI disturb the microbiome, which predisposes the child to more allergy. If I think real reflux disease in infants exists in 2%, 5% maximum. That's the population with acid reflux disease, which should be treated with proton pump inhibitors. But that's a relatively small group compared to the whole group with those symptoms of discomfort, which should be treated with nutritional treatment.
Yes, yes. Thank you very much. And bringing up the topic of microbiota, because we're having lots of questions on this. So can I ask you now, what do you think of the alterations in gut microbiota that can accompany cases with allergy? And do these patients really benefit from addition of any one of the family of biotics, pro, pre, syn, whatever? This is lots of questions on this topic.
Yeah, well, it's the hot topic, of course, is the microbiome. First of all, there are some quite old data that infants who develop allergy do have a different microbiome before symptoms develop from those who do not develop allergy. So microbiome composition seems to be a predisposing factor to develop allergy or not. And that's probably partly related to epigenetic factors. So it's probably our genes which in part select the colonization, but can select the colonization at risk for allergy. Now, the recent movement into the management of cosmic protein allergy is to add prebiotics or to add probiotics or to add human milk oligosaccharides to the hydrolysate, to the amino acid-based formula, which is probably not a bad idea, but there are not yet comparative trials to say that it's really going better with the addition. But there is certainly some logic to try to normalize the gastrointestinal microbiome in allergic infants.
Okay, Professor Hodhod, I think, do you agree with this? That the alteration of the microbiome?
Of course, this is expected. And, you know, Professor Marwa, in our community, in certain areas in which over-hygiene is not practiced, actually, they have little allergy. And
interesting.
I'm not discussing here the hygiene theory, but
I know.
Those who are overdoing the hygiene are more allergic. Actually, I will remember in my village, I'm coming from a rural origin, and one of the old women in my street used to use stool of newborn healthy infants to put them on the food for sick persons, whether they were allergic or malnourished, and she was very successful compared to the physician's results.
Yeah, well, absolutely agree. So we will get an explosion of allergy in a couple of years after COVID with our very hygienic
very hygienic practice. Yeah. Okay. So another few questions on the symptoms of cow milk allergy, Professor Yvan. When to suspect allergy as a cause of infant colic?
Yeah, well, that's also a very good question. I think overall, again, my answer would be the same. If that infant colic is in combination with other manifestations, then you rather go for allergy as a possible diagnosis. Also, you can look at the family history of allergy and consider that also as a risk factor. And there are quite some studies that an extensive hydrolysate is effective in management of at least a subgroup of infants with colic. So it's one of the causes of infantile colic.
Okay. Constipation, the other question?
Yes, also. Constipation and diarrhea are manifestations of cow's milk protein allergy. We don't really know why constipation is a manifestation, but yeah, it's certainly changes in stool consistency seem to be one of the symptoms of cow's milk allergy.
Okay, I'll be back to Professor Hodhod because I know you have special interest in infants with colics and constipation. Do you have to add anything in this topic?
Actually, in early 90s, we studied infant colic in many master and PhD theses, and we found that it's only in severe forms of colic that we can consider allergy. Actually, if it is a mild pathology, you cannot find allergy in. And in one of the studies, we found that a percent of cow's milk allergy in infant colic that is mild to moderate was only 2 to 3%, which is similar to the normal population. And it was almost 60% in patients with severe forms of colic. This is regarding colic. And regarding constipation, in our publication about constipation, cow's milk allergy in pediatric allergy and immunology, I think it was 2009.
Yes,
the endoscopy of these persons having constipation that is intractable, and you remember, Professor Marwa, that your PhD thesis were about constipation and colonoscopy in constipation, and we found that inflammation occurring with allergy may be a cause as well. And another observation is that constipation induced by allergy is unique in one area in which it can come at older age, like early and late childhood. We meet it in early and late childhood compared to other cow's milk protein allergies that occur usually in infancy.
Yeah, okay. Thank you very much, Professor Mostafa. And I'm keeping the last question for this open discussion on the difference between cow milk allergy and lactose intolerance, and if they can coexist. I'll have to listen to both of you on this very hot question. Can you start, Professor Mostafa, of course?
Actually, is there a link between both? You know, Professor Marwa, that lactase is located in the small intestine.
Yes.
And actually, small intestine may be involved in FBIs. And only in this condition in which cow's milk allergy may be associated as well with lactose intolerance. But the differences are in different presentations, it's clear. One is coming with bleeding and the mucoid stool FBIAB. One is coming with this picture of severe diarrhea, abdominal distension, perianal soreness only, and acidic stool. This is the lactose intolerance. And lactose intolerance, secondary lactose intolerance, is usually following something like gastroenteritis, and you can take it in history. But in primary types or congenital types, you can find them very rare. They are very rare. They are not there. And the adult type will usually occur later in life. So the differentiation is usually not needed, but sometimes it is difficult. And actually, I met many persons coming diagnosed as lactose intolerance and receiving a lactose-free formula. And after something like few weeks, blood started to appear in the stool. And the diagnosis was from the very early beginning an allergic disease. And actually, this is very tricky zone. And they need to maintain him on lactose-free for at least a few weeks to find out if something is developing as well, like other manifestations of allergy.
Yeah, thank you very much. Professor Yvan, I'd love to hear your comment on this.
Yeah, well, I can again only agree. And I think that somehow the PPI or lactose intolerance has some similarities because our colleagues, or we trend to overdiagnose it.
Yes.
And I think that to put it black or white, that primary lactose intolerance does not exist at this age in infants. And it's always secondary to something. And so yes, cow's milk allergy can start with lactose intolerance if you have an atrophy of your small bowel villi, as was explained. But then as soon as you treat a cow's milk allergy, the lactase is back again. And you can then give formula with lactose. So lactose as primary intolerance, as primary diagnosis, does not exist. And as soon as you treat the cause, the lactase reappears and the symptoms of lactose intolerance would disappear.
Yeah, okay, so that was very enlightening. Thank you very much. So this interesting question that came from Germany, the doctor says that in Germany they do not see lots of cases, or they do not diagnose lots of cases with cow milk allergy, and he was asking if this might be related to how the cows or the cattle are bred, and what do you think? I haven't been there. I don't know. I don't know.
Well, I would just like to say that worldwide there is agreement that the incidence of cow's milk allergy is somewhere between 2 and 5%. But again, it depends on how selective your criteria are.
Yes.
Because in the EuroPreval study, it was only 0.5%.
Yeah.
But if you only take the children which react during the half day of challenge test, you only take the immediate reactions and you forget about those who react after 2-3 days of ingestion of cow's milk. And that makes it, of course, an open debate, because or you're a believer or you're not believer, but you have no hard scientific proof
yes.
of that. But so I call it symptoms related to the ingestion of cow's milk protein, and don't discuss the mechanism behind it anymore.
Yeah, this is a safe definition, symptom related. Okay, so another questions on the
Can
symptoms.
I ask Professor Vandenplas,
sure.
Marwa, please?
Yeah, sure.
There was a publication, Professor Vandenplas, I think 2000 something, about the distribution of cows breeding and the prevalence of lactose intolerance. You know, this paper with the map of distribution inside, and they said that there is coincidence between heavy breeding of cows and decrease the density of lactose intolerance. Do you think the same will happen with cow's milk, and this is why cow's milk allergy is not very highly reported in Europe compared to other parts in the world?
Yeah, could be. And although I also think that in a lot of parts of the world, infants do develop a lot of symptoms because of infectious diseases, which we see much less. We have no parasitic infections, for instance, which is frequently occurring in hot tropical countries. Although it was today 35 degrees in Brussels. But so I think it's very difficult to compare, and that a lot of infants develop symptoms which probably difficult to prove again that they are allergic, but related to what they are ingesting.
Oh, okay, so that was clear. Professor Vandenplas, in your presentation, you pointed out that infants with functional GIT disorders might show some improvement on a diagnostic challenge. So can you elaborate more on this? Because there is a question on the symptom severity.
Well, again, it's the open debate, and I myself have no answer to the question where functional gastrointestinal disorder stops and where non-IgE mediated allergy starts, because I personally think we're talking the same, but from a different perspective. The allergologist calls it non-IgE mediated allergy, and the gastroenterologist calls it a functional gastrointestinal disorder. But we both have no way.
I think we have a problem with the voice sound. Professor Mostafa, you still hear me?
Of infants which develop tolerance rapidly at the age of 1 year. So it's more to do with maturation.
Connection of Professor Van.
Yeah, connection is interrupted, unfortunately. Okay.
He will come back.
Okay. Yeah.
Yes.
Professor Yvan, we couldn't hear the last part because connection was interrupted.
Yeah. Okay.
So the last part that we can't really differentiate, is it functional or allergic?
Do you hear me now?
Yeah, now it's perfect.
Okay. Yeah, there is a thunderstorm coming.
Okay.
So that's me.
Connection is interrupted again. So
not possible always to separate them clearly.
Yeah, thank you. I think that was clear that still it's not possible to separate them. So I'm so sorry for every attendee that I couldn't complete some questions on the symptoms because they were not really related to our topic on cow milk allergy. They were interesting, of course, and I'd like to ask you both about them, but we still have lots of questions on investigations and management. So I'll move to the part on investigations. My question to you, Professor Yvan, because we have what I can call a standard panel of investigations.
Sorry, I did not get it.
A standard panel of investigations that it's known to doctors here in Egypt. That's the serological testing you mentioned, the occult blood and stool, and the fecal calprotectin. I want to hear your opinion on these tests for the diagnosis or for aiding the diagnosis.
Yeah, well, I personally think that it's mainly elimination and challenge, and the rest can be helpful, but it's not mandatory. What we said in the guidelines is that you do IgE and skin prick test or not. It's open to the physician to decide, and it depends so much from country to country where it's regularly performed or not. But there are so many negative tests that it does not really help. The same is true, I think, for occult blood. Because it's so frequently positive. So it's also positive when you have an infectious disease, when you have some inflammation. So it's indicative. And the same is true for calprotectin, which has so huge variation in normal ranges in young infants that it is probably not a good age where calprotectin is very useful, except if it's extremely high. But the normal range in young infants is so large that you cannot really use it as a diagnostic tool. And again, it will also be positive when there is inflammation, not caused by allergy, but by another mechanism.
Yeah, okay. So it's always the suspicion and the challenge test, right?
Yes.
Okay, thank you. Dr. Mostafa, would you have to add anything? Because this is a practice that I know you see every day.
Actually, physicians, because of they are busy persons, they don't give time for focused allergy history and examination. And so they rush for investigations. Another point is that some of the population, because they are not health educated well, need something solid to depend on. So I think this is a drive for some of the colleagues asking a big list of investigations that are mostly not helpful in this condition. And even asking for IgE, is not of help in non-IgE mediated diseases. And I agree totally with Professor Vandenplas that most of these tests are very misleading in the
sometimes they might mislead,
in the definition and diagnosis of the clinical condition, especially on individual basis. And many cases coming with this what's called occult blood in the stool. In Arabic it's الدم الخفي وأنا مسميه اللهو الخفي.
So it's like a ghost.
It's a misleading test, so that it leads to many confusions in the decisions.
And so the calprotectin.
Yes, when I started discussing the cow's milk allergy issue in 1991, This was my first talk about cow's milk allergy in Egypt. You know, Dr. Marwa, it was, the pendulum was at the extreme of rejection and denial.
Yes.
Of denial. And in 2010 onward, we reached the opposite side, the overdiagnosis of allergy. And from this point exactly, I started to diagnose the rare conditions like very early onset IBD to have this collection, because actually they start the elimination. And if it is actual cow's milk allergy, it will improve. And those who are not improving will come to me, and they are not allergy. And I'm going to diagnose.
And that's how you pick them up.
Yes.
Okay. So I hope I covered most of the questions, the symptoms and investigations. And I don't know if you'd be happy to hear this from me. The big part is on the management. So this was not the big part of the questions. I'm so sorry. So I'll try to be very targeted here in the part of treatment. So question to Professor Yvan. It's a very direct question. When to start amino acid formula in a case of cow milk allergy?
Yeah, well, the answer to that is not so straightforward. I think it's whenever the symptoms are very severe, life-threatening, anaphylaxis, when you think the child is allergic and does not respond to the extensive hydrolysate, that is what is in most of the guidelines. But of course, it depends also on availability of your formulas. You need to have extensive hydrolysate. Yeah. And it's only this way in guidelines, because amino acid-based formula is in most part of the world so much more expensive than extensive hydrolysate. Mm-hmm. So I think if tomorrow the cost of amino acid-based formula would be the same as extensive hydrolysate, all our guidelines would probably change. So the reason why most scientific societies recommend extensive hydrolysate is mainly also for socioeconomic reasons, because amino acid-based formula is so much more expensive than the extensive hydrolysate. And it also depends on how easily you can follow the child, because 5 to 10% of the real allergic children will be allergic to the extensive hydrolysate. So if you cannot organize a follow-up, then I would go for the amino acid-based formula, because then I'm sure that the child is being well treated and will not still be allergic to the extensive hydrolysate. But overall, extensive hydrolysate first. If that does not improve, amino acid-based formula. Life-threatening situations, you start with amino acid-based formula.
Yeah, thank you very much, Professor Yvan, for this clarification, because this answers actually a question coming from Kuwait, in which the professor says that the amino acid formula and extensively hydrolyzed formula are all available. So I think you answered this. It's safer to give an amino acid formula if you can't establish a follow-up for your patient. Thank you very much. Thank you. So can we start amino acid formula as early as neonatal period, even in a preterm in the NICU? This is a question.
Professor Mostafa, who is going to answer?
Yeah, sure.
Actually, I presented this paper, this original research about amino acid-based formula in preterm with feeding intolerance.
Yes.
And I will, because this question was asked, I will elaborate more, because it was a practice in non-evidence-based practice in Egypt, in NICUs, many NICUs in Egypt in the last 4 years, in which they tend to use the amino acid-based formula once there is feeding intolerance. Nowadays, researchers are giving this, like the one I presented about fecal calprotectin and GI symptoms improving after, especially for the feeding intolerance, after giving this amino acid-based formula. And I think there is no problem with this, provided there is feeding intolerance in spite of all other regimens given, you can think in.
Yeah, thank you. Thank you very much, Dr. Mostafa. So this question is directly to you, Professor Hodhod, on the effect of amino acid formula on the growth and the general growth, and the bone development. And does the choice of the formula, of the amino acid formula, differs as regard the vitamin D and calcium content?
Let us stress it again. This was mentioned in the talk, but
Yes.
let me elaborate more.
Yeah.
So regarding the grass, all studies done demonstrated that amino acid-based formula and extensively hydrolyzed formula will achieve near normal grass, although it's not very similar to the standard ordinary formulas, but it's very good for this clinical context to achieve this rate of growth. And actually, ourselves in our department, we studied the growth rate on soy milk and amino acid-based formula. As you know, this was the PhD of Dr. Ahmed Tuhami, one of our colleagues, and head by Professor Sana Youssef. And they didn't find any difference in the growth parameters between those on amino acid-based and those on soy-based formula. And you know, the soy-based formula was used because of availability issues of amino acid-based formula at that time, something 10 years ago. It was 10 years ago. So what about the bones? Actually, there was an issue concerning the bone and its development. And amino acid-based formula should have a little bit higher concentration of calcium.
Yes.
And what about the fat blend I discussed? You know, oleic acid, if it is free in some of the conditions, you know, the triglycerides are having 3 positions.
Mm-hmm.
And the one in the center will not leave the glycerol, and it will form the monoglycerides, and this will be absorbed as such. Mm-hmm. And the 2 other peripheral and fatty acids will be released. So these 2 fatty acids will be released. In the breast milk, most of the oleic acid is in the center, so it's absorbed. And if you are going to use this oleic acid, you should have 2 things. To decrease its concentration, but by using a special fat blend, or by replacing the oleic acid to the position, central position of the triglycerides. And studying the fat blend is very important, not only studying the calcium content, vitamin D content of the formula.
Mm-hmm. Okay, thank you, Professor Mostafa, for this elaboration. And because you just mentioned the soy formula, so I have to ask Professor Yvan a question about the choice of soy formula in patients with cow milk allergy, especially in the IgE-mediated reaction. And this is the exact question.
Okay. Now, the answer for Europe is simple. We don't have soy-based infant formula anymore on the market. So no option. The answer...
And the answer for Egypt, because we have...
is, I think that soy is not recommended as a first choice, but in case that hydrolysates are not available or too expensive, if the family cannot not purchase it, I think that soy is a very valid second choice in the treatment of cow's milk protein allergy after the first choice. And there is 10 to 15% cross reactivity, but that means that soy still works in 80% of all the infants with cow's milk allergy. And it works better if there is IgE mediated allergy than in non-IgE mediated allergy. So it's not first option, but if it can be in certain circumstances, the best option, because it's better to feed soy than to feed nothing.
Yeah, I personally thank you very much for this clarification, because Professor Mostafa, going back to you, I think before the era of amino acid formula or the extensively hydrolyzed, when it was not very easy to find, I think sometimes we had to use soy formula. What do you think?
Yes, we were using it, and Actually, I think the cross-antigenicity between soy and cow's milk allergy in our community ranges between 5 and 10% of the conditions. We were in dilemma in the era of soy because these 5 to 10% of population we were not able to feed, and usually we imported for them either the extensively hydrolyzed or the amino acid based formula according to availability in the near region, like in the Gulf region, for which type of milk available or formula available.
Okay, so to sum up this issue on soy formula, because while we're talking, I'm getting more and more questions on the soy formula. It's not the obvious choice, but if it is the available one, so it's better than nothing, right? So I'm getting this clear.
Yep.
Okay, thank you very much. So other milks, Dr. Mostafa, you have a question on your experience on the use of camel milk. You mentioned in your presentation that it was not very successful, and we have this question from Saudi Arabia.
I know there are some studies now running in the Gulf region about camel milk, but my experience was using the raw camel milk, and I think now they are trying to have manipulated or processed the camel milk. But when I used it in almost not less than 500 patients between 1992 and 1995, actually, you know, Dr. Marwa, that I have a database for my clinic.
Yes.
And when I analyzed the data, it was disappointing. And I stopped this practice in my clinic in 1995. I'm not sure, because I heard from some colleagues from Saudi Arabia that they are having a newer study on camel milk. When they publish it, and many publications will be available, I will go through to see their methodology of preparation of this milk and its safety and efficacy in the treatment.
Okay, so Professor Yvan, the other milk, the goat milk, because again, we're getting lots of questions from the Gulf area on the goat's milk in particular.
Yeah, well, I think for goat, it's more obvious than for camel milk, because goat is for 80–90% the same kind of protein as in cow's milk. So it's complete overlap. But on the other side, that means that if you give 100 infants which are allergic to cow's milk, goat milk, it will work in 10 to 15%. So you always have people who say, yes, it does work. And I think the same is true for camel milk or donkey milk, which is popular in Italy, or horse milk. And it's also very important that before allergy, nutrition is much more important.
Yes.
So I would say infant formula, the composition is very important, and raw camel milk or raw goat's milk is certainly not appropriate from the nutritional point of view.
Yes.
And forget about allergy. Nutrition is even much more important.
So I'll take it from here and ask you about the other milks that Professor Hodhod just mentioned in his presentation. I'll hear your feedback, Professor Mostafa, in a second, on the rice milk, other nut milk, almond or whatever.
Well, there are two kinds of this kind of formulas, I think. Most of them are, and again, nutritionally not adapted at all for nutritional needs of infants. Yes. So it's just rice milk is very often just water in which milk has cooked. Yes. So never do that. But especially in Europe, there is a trend that some companies start to develop infant formula based from nuts, based from other vegetable origin. And I think there will also be allergy to those kind of formulas because it's with intact protein. Yes. But at least then they are nutritionally safe. That is appearing on the market. And then the future have to teach us how frequent those children are reacting to those other food allergens, because nuts are known to be quite allergenic.
Yes. Yeah.
So I don't think it will be a solution for a majority of infants. And I think that the experience will be just like for camel milk. You give cow's milk, 100 cow's milk allergic infant camel milk, it will work in 30 out of the 100 or 40 out of the 100, but that's much too low to recommend. And probably the same will happen with those formulas from different protein origin.
Yeah. Yeah.
The rice which is in Europe on the market are infant formulas based on rice hydrolysates.
Yeah.
And that's totally different.
Yeah.
That's infant formula, which is nutritionally totally safe. And it's hydrolyzed rice protein, and that works very well.
Yeah.
And that's totally cow's milk free and is much cheaper than amino acid based formula, for instance.
Okay, but that's completely different from the commercial rice milk, which
absolutely.
is totally, thank you for this. Thank you. Professor Mostafa, I need to ask you one more question on this milk alternatives, our milks, about can we give rice milk, because this is a question, to a lactating mother, to a breastfeeding mother, to a child or an infant who's allergic?
Rice milk?
Rice, yes, to the mother.
Rice milk is already prepared pharmaceutically, and it was hydrolyzed rice milk. This is accepted policy for both infants and mothers. But rice forms that are available in market commercially are, we are afraid of arsenic contamination. Okay. This is not only about the nutritional status, but the arsenic. We are afraid of arsenic. So take care because yes. Myself, I met many mothers having features of arsenic intoxication by overusing these commercial rice-based formulae.
Okay, and what about coconut milk?
This is not milk. This is milk by name, but not by nature. It's not a balanced food even. It's not a balanced
I mean to the mother. I'm not discussing it today.
We should call it drinks and not milk.
Yeah, it's drinks. Refreshment.
And I think mothers can eat and drink more balanced foods that are nutritionally balanced. And here I should stress that clinical nutrition is becoming a specialty. And we have in Egypt many professors who are clinical nutritionists. And in Shams, we have a very strong team. Professor Sana Yusuf, Professor Ihab Khairi, Professor May Nassar, Professor Yasmin Gamal. In fact, they can help a lot to advise regarding a balanced diet in these persons, because even weaning or what's called complementary feeding for infants needs the support of a nutritionist.
Yeah, okay. Professor Yvan, I have a question that I think you might like to comment on. As from Professor Osama Ashir from Asyut University is asking about the composition of a hypoallergenic formula. Being whey-based or casein-based, does it really make a difference, the extensively hydrolyzed formula?
No, I don't think it makes a major difference whether it's whey or casein-based.
Okay, so it's the same. Both are same, equally effective.
So that's what we did in Belgium. Is I compared the Altera, which is a whey hydrolysate, to the Nutramigen, which is a casein hydrolysate, and the outcome was it was just as equally effective.
Okay, so that's very nice. I have some questions on the partially hydrolyzed formula, the position of the partially hydrolyzed formula in management of allergy, starting from diagnosis in the challenge test, and then in using it as a formula for treatment, and again in reintroduction of each challenge. So can you start on this, and I'll listen to Professor Mostafa.
So it's okay. Partially hydrolyzed formula is intended for prevention, and it cannot be used for elimination testing. It cannot be used in a definitely diagnosed case of cow's milk allergy. And I will be happy to share with you the results of the very recent work that is not discussed yet. a PhD thesis by Dina Haider, supervised by Professor Ahmed Hamdi and myself. And in this state, we compared the patients with cow's milk allergy taking the amino acid-based formula for 6 months, then shifting into partially hydrolyzed formula, and those continuing for 1 year. And we discovered that it's significantly different, with favoring the process of administration of a partially hydrolyzed formula after the 6-month use of amino acid-based formula. And this may open a new era of shortening the period of use of amino acid or extensively hydrolyzed formulae in the treatment of cow's milk allergy. I cannot share more results of this study because this thesis was not discussed yet, but I shared with you the results.
Yeah, so that's very good. Professor Yvan, would you like to add more on the use of partially hydrolyzed formula in allergy?
Well, I fully agree that partial hydrolysates do not have a place in the management of cow's milk allergy. They should rather be regarded as an alternative to formula with intact protein.
Yeah.
What we in the Middle East guidelines, we did put the partial hydrolysate as a formula to give as a in the challenge test, indicating it has no place in the management, but use it as a formula for a challenge test. And I'm convinced that what was just said by Professor Mostafa is completely right, because there are data from old studies from John van der Hoof in infants not tolerating extensive hydrolysates, put on an amino acid-based formula for some months, and then put again on the same extensive hydrolysate, and they tolerated it. So I think there is a difference between getting infants symptom-free and treat them where you need the best, the most effective. But once they are symptom-free, then you can probably give less hydrolyzed formula, which will be tolerated and not reintroduce the symptoms. So it's once you're symptom-free, partial hydrolysate may be useful to keep the patient symptom-free, but first you need to eliminate the symptoms with extensive hydrolysate or amino acid-based formula.
Yeah, thank you very much for this elaboration. Actually, we're joined right now with two of the authors in the Middle East consensus on milk allergy, Professor Gamal Sami and Professor Sana Youssef. And I think this is a clear input on the use of partially hydrolyzed formula. Thank you very much on this. So I have a question from Iraq on a changing paradigm of management in cow milk allergy, from elimination to exposure. What do you think of this?
It's a new tendency.
It's brainstorming.
From a passive, no. This is a publication that is 2019.
I know. I think Professor Dr. Khalid needs to hear your input on that.
Yes, it is another future thinking, moving from the passive attitude to the proactive attitude.
Yeah.
From the passive attitude of just elimination and waiting for the natural tolerance to happen, to induction of tolerance itself. And I think the coming era will be for the induction of tolerance. And the recent publications, especially on experimental basis on the immune system, I guess they will proceed more rapidly in the next few years to define more and help more for development of tolerance to allergic foods. You know, and the audience all know that we moved from late administration of allergic foods that was a habit in the 1990s to early administration that decreased the incidence of allergy. And you remember the studies of EAT and ElDeeb and this for the prevention. And I think the same will happen later in developing tolerance.
Yeah, thank you very much, Dr. Yvan. I'd like to hear your input on that.
Yeah, well, again, I do agree, although oral immune therapy, that's induction of oral tolerance, seems to work much better for peanut and other food proteins than cow's milk protein. So the literature on in oral immune therapy for cow's milk protein allergy is relatively disappointing. But again, as we just discussed, that may be a role from the partial hydrolysate, because the difference with the EAT and ElDeeb studies, peanut is a yes and no, you eat it or you don't eat it. With partial hydrolysate, you still give peptides from cow's milk protein with reduced allergenicity. So it's not a yes or no, you're in the middle there, and that may help to introduce oral tolerance. And to come back to the microbiome, that plays also probably a major role in the development of that tolerance.
Yeah, thank you. Thank you very much. I have a question from Professor Dr. Ihab Khairi. He's the head of the Clinical Nutrition Unit at Ain Shams University. He's asking about if we have a very strong family history of allergy, would this change the plan of management? If the infant is having a strong family history?
For prevention or
for prevention and for treatment, yes.
Well, for treatment will not change because the treatment is exactly the same.
Yeah.
And regarding prevention, it's heavily debated these days.
Yeah.
I think that today none of the guidelines, the recent guidelines, still recommend partial hydrolysates for prevention, although it has to be said that it's probably also product specific, and if you put them all together in a basket, your outcome is different than if you study hydrolysate per hydrolysate. So we should not globalize it because they are probably specific, and misinterpretation of a lot of colleagues or institutions by that is that partial hydrolysates are not dangerous. They are certainly not harmful. So I think the knowledge today is a partial hydrolysate maybe prevents or maybe not prevents, but certainly does not cause harm. So it's a question of maybe benefit or no benefit at all. And then, of course, if you look at it pure scientifically, you cannot recommend to use because there is no hard evidence for the benefit. But from the practical point of view, you do no harm, and maybe it's better, we don't know, because absence of evidence is not evidence of absence.
Yeah, okay, so that was very clear. Thank you, Professor Yvan. Professor Mostafa, would you like to add to this?
May I ask you, Professor Vandenplas, about, I will share with you some of my findings in preventive effect of partially hydrolyzed formula, because you know that publications are controversial in this issue. Some says yes, some says no, and some of the recent guidelines denied this effect. But when I came back to the why they didn't find a difference, one of the points which I collected among almost more than 500 infants using the partially hydrolyzed formula, I considered which rank of the infant in the family, because if the allergy is risk is something 2 to 5% in the firstborn, because this is a normal population. If he has a SEB with allergy, the risk is higher. And if he is the third one with 2 histories of allergy, the risk is more higher. And in this work that I'm ready to publish is ranking according to whether he is the first case in the family or the second case with a previous history or a previous 2 histories. And I compared the effect of partially hydrolyzed to breastfeeding and ordinary formula feeding. And the difference is very clear and sharp when you compare first to first, second to second, and third to third. Do you agree?
Yeah, it's very interesting, and I'm absolutely a believer of your hypothesis. And I think it's also very important that you look at the different studies when the randomization was done, because a lot of the recent studies include infants even up to the age of 1 month, which means that they first had 3 weeks of intact protein and then were switched to the partial hydrolysate. And that's, of course, not what you want to do in a scientific correct setup where you want to study the effect of the partial hydrolysate. So I'm a believer of the partial hydrolysate, and I'm very happy with what you came to say. And so please publish it.
Okay. Is there more questions?
Hello.
Yeah, we'll just have few more questions. The question from immunotologist, a very recognized immunotologist here, asking, sometimes in the NICU, they face cases with severe GI intolerance and bleeding, a picture very much that resembles necrotizing enterocolitis. So is allergy here a plausible diagnosis? To Mostafa?
Direct to me or to Professor Vandenplas?
I'll hear both of you.
You start.
Huh?
You start.
You start.
Yeah. Okay. Actually, the line of demarcation between neck and allergy is very confusing. And I cannot differentiate both from each other. And according to the publication of trial of amino acid-based formula from our colleagues in Egypt, I know many of them are using, and the many others are claiming and accusing the use of this amino acid-based formula in these persons. And I think if your normal management plan for neck is not proceeding in a well way as you expect as a neonatologist, you can take this trial of amino acid-based formula use. Why not? Nothing to lose. You have done all what you want and all you want know and all what you can for this neck, and patients are not improving, and food intolerance is very significant. Feeding intolerance is very significant. You can make this trial according to the latest publication I have shown in my presentation. Okay.
Yeah, thank you, Professor Mostafa. Professor Yvan.
Agree.
Okay, that was short. Thank you. Short and direct. Yes, it's very possible, of course. So I know you're getting tired, but I'll give you some good news. We only have 3 more questions.
Okay.
Okay, and I'm being kind. They're not actually 3, but I'll just make them 3. The question is on the use of formula in the diagnostic challenge or in the first diagnosis of allergy. Could it be amino acid or extensively hydrolyzed? I'm asking you, Professor Yvan.
Well, that's more or less a question we had before.
Yeah, I know.
So I think guidelines say for most of the symptoms, except eosinophilic esophagitis and Heiner syndrome, to start with extensive hydrolysate as the first option.
No, I don't mean that. Sorry, I meant if you're just in the process of diagnosing, you still diagnosis. It's the challenge, the diagnostic elimination. Can you start amino acid or extensively hydrolyzed?
Well, you can start with either, but the guidelines say to start with extensive hydrolysate for again, mainly economic reasons.
Yeah.
And I think if you want to be 100% sure,
yes.
Then you start with the amino acid based formula.
Yeah.
And if the symptoms disappear, you switch the child then to the extensive hydrolysate. That would be also a very logic way to go. You start with the best first, and then if the child does not improve, it's definitely not cow's milk protein allergy. You eliminate it for 100% sure. And if the child improves, you can, after 2 to 4 weeks, switch to the extensive hydrolysate and see if that is tolerated. But that's not what most of the guidelines say today. But I would be in favor of such an approach because it has some logic that you start with the most effective treatment first.
Yeah, thank you very much. Professor Mostafa, do you agree on that?
The same step up or step down.
Yes.
Yeah, that's
come
it.
from above or come from below. But in my practice, I usually, in the elimination test, I use the amino acid based formula to get sure, because if they are not responding, I will think immediately in other conditions and proceed more further for investigations. You know, these investigations are not only invasive, but very expensive as well. So I prefer starting, although I know some guidelines, this is not the guideline approach, but I prefer starting with amino acid. And when we performed the Egyptian guidelines, we said that it's better to start with amino acid in the elimination study. That the shift later to other modalities will depend on the type of the disease.
Okay, thank you very much on that. We have questions, a group of questions on the multiple food allergy. Yeah, I'll just group them together because I know it's not the main topic of today, so I kept them for the last. Group of questions on when to suspect and how to manage multiple food allergy, and when to suspect and how to manage eosinophilic colitis, eosinophilic esophagitis, I mean. So I know it's not the exact topic for today, but we're getting lots of questions, and I would like to have your concise input on that. Professor Yvan, would you like to start?
Well, for multiple food allergy, I think you stop everything and you start with amino acid based formula and you see what happens. Child should go better. That's the short answer. For eosinophilic esophagitis, I'm puzzled there because the guidelines all say amino acid based formula, but no one ever tried extensive hydrolysate. There is simply no study. And there is one study in adults where extensive hydrolysate did work. But I think that for young infants with eosinophilic esophagitis, cow's milk allergy is probably the cause. And so an elimination diet, and today the guidelines say amino acid based formula is the way to go. It's different for older children where you could, to my opinion, start with topical treatment and not with the elimination diet of the 6 most allergenic foods, because that's so complicated for those children to do, although guidelines there also say to start with the elimination diet.
Okay, so that was short and precise. Thank you very much. Professor Mostafa, I'd like to hear your comment on this too.
I know my colleagues, immunologist colleagues, are against the concept of multiple food allergy, but actually it exists. And there are many persons who are allergic to many foods. But in my experience, if you find allergy or reactions to many foods, actually think something else other than multiple food allergy. Think eosinophilic GI disease, and or more recently, what we discovered on analysis of secretory IgA, and we found this very, this is another work with DK.
Yeah, this is another question.
Dina Abdelhamid and Professor Vandenplas, we tested the fecal and salivary IgA in food allergies. And we discovered that this category is very high in our community. And imagine with us that when we administered a probiotic for these persons, the secretory IgA increased, and the child became, the infant or child became more tolerant to many foods. I started this because some of the mothers came to me with elimination of everything. She is emaciated, she is killed, she have been died. So I think this is not usual. This is not the case with multiple allergies. So I started this tracing of the secretory IgA deficiency, and actually its percentage in Egypt was very high. I don't have the numbers with me now in these two studies, one study on the salivary and the other on the fecal antigen. And I think this area should be traced and analyzed, especially in what's called multiple food allergies. And it will be another era opening the mind to another explanation in which, because we know that secretory IgA is one of the factors preventing allergies or leading to tolerance from the very early beginning. And if it is deficient, you can have this category of multiple reactions. And one of the features of this disease as well is that it is very not consistent, so that the mother will tell you that he is taking this food now, he is intolerant. After a while, she said, it's okay. After a while, she's going to tell, this is bad. Think in secretory IgA deficiency in this category, especially if fever is coming in many attacks of the GI diseases with this. You can think in very early onset IBD or secretory IgA deficiency with small bowel bacterial overgrowth.
Yeah, that was very enlightening, the part on the IgA. Thank you, Professor Mostafa, very much. We're still having questions if you would like to have some more, mainly on the same topics. I believe that you answered most of them. I personally am very happy with this session. It was enlightening to me in many, many different ways. Thank you, Professor Yvan, and thank you, Professor Mostafa, very much. We're getting, by the way, a lot of thank you and congratulations on this very nice lectures from eminent professors in Egypt and all over the world. So thank you very much. Thank you. It was my pleasure. It was my pleasure. I'll call for a second for Professor Wael to join us.
Yes. Thank you very much. Thank you very much, my dear professor, for excellent presentation and discussion. And special thanks also to Professor Marwa for excellent moderation.
It was my pleasure. I thank you very much.
I think you covered by your questions all items about cow milk.
And I'd like to apologize for each and every attendee that asked a question that I couldn't convey to the speakers. I'm so sorry for that, but I tried to cover the most relevant questions.
Yes. Yes, it's a very nice presentation, very nice, useful webinar. And also special thanks to Abbott Nutrition, supporting the medical community actually by decreasing the price of its product Similac, or by supporting medical event like this Waves Nutrition Virus Wave. Also thanks to Quartz Even Solution, yes, Dr. Wissam and the whole team for excellent technical support of these webinars. And finally, I'd like to announce the upcoming event by Egyptian Academy of Pediatric and Egyptian Scientific Society of Pediatric and Immunotherapy. We have next Monday in the second wave of endocrinology beers, and next Wednesday, the first wave of nephrology beers. And next Friday, we have the third wave of nutrition beers by Professor Flavia Indriu and Professor Marwa ElDeeb with Professor, and the Professor Yasmin Gamal, Professor Yasmin Gamal, and the moderation will be Professor Osama Al-Aishi. So the next week we have 3 events. We would like to all participants and all pediatricians and all colleagues to wait for us and fix your agenda. Thank you very much, Professor Vandenplas. Thank you, Mostafa, and thank you, Professor Marwa. Thank you very much.
Thank you. Thank you. It was nice to be with you.
Bye.
Bye. Bye. Bye. Bye.